My name is Duane Davis. I am a cardiothoracic surgeon. I got involved in transplant at the tail end of my residency in the late 80s and early 90s, and really fell in love with it and was introduced to ISHLT in 92 and found it to be a home from a standpoint of multidisciplinary care and the science and innovation that was necessary to really move the needle in terms of taking care of the patients we were blessed to serve. I was a program committee chair and then was on the board for quite a long time, in addition being president when we were in Washington, D.C., and have enjoyed watching the growth of the organization and the diversification of the teams that are involved in the organization. So, transplant, like any new innovation in medicine, goes through the periods where it starts off being, frankly, very experimental. And you're dealing with life and death, and so the experimental procedure gives you the opportunity to cure or materially alter the lives of individuals. But the outcomes, if you're looking 4 decades after, are just not really what we would consider acceptable. So in the field of lung transplant, and you look at what the survival was in the 80s, it was 75% 1-year survival, and the variability of the outcomes were incredible. And I always break down transplant in terms of, I always give the talk of there are 175,000, 180,000 deaths in the United States from lung failure. We're now doing 2,700 lung transplants. That's a pretty significant gap between those who die of lung failure versus those who are able to benefit. So there's never enough in terms of the actual donors to be able to materially alter the vast majority of individuals who have the organ failure. And it gets worse when you talk about heart, renal failure, liver failure. There's also the question of how the organs work right away, and what are the things that we can do to improve that. So when I started, we never were sure how the lungs were going to work coming out of the operating room. And that's not a very good feeling if you're the surgeon or the team that's taking care of a patient who you thought you did everything the same way you did to the patient who did extremely well, and this patient who is suffering severe graft dysfunction. Then it gets into the long-term survivorship after transplant, and that you've traded diseases. You have to be on immunosuppressions that are basically poisons. It has impacts in terms of cancer risk, infection risk, as well as the damage to the kidneys, liver, and other components of it. So when you look at it, those are the big problems. Now, we have moved over the decades tremendously. If you look at the outcomes in the early 90s, late 80s to now, we're expecting a 90% plus 1-year survivorship. When you look at long-term survival, it's better, but particularly with lung transplant, it's nowhere near where we would want. So if I'm seeing a 20 or a 30-year-old, I'm saying that getting to be a 30 or 40-year-old, yeah, we got a shot at that. But you're not going to be a 50 or 60 or 70-year-old, or that's a low probability of doing that. So we still have tremendous work to do. And when I have individuals, whether they're medical students or residents, and they're looking at what should they be focusing their careers on, those are really big, important questions. And how can we actually achieve long-term survival in these and actually have enough organs to put into all those who would benefit? And those have been areas of focus during my career that I've been blessed to participate in. Think of things that you do that look like they're never going to yield anything. So, doing xenotransplant in the 90s and early 2000s to now where it's still experimental and we don't know if it's going to work, but there is more of a hope that we be able to achieve that. And then looking at what are potentially really long-term solutions. We were blessed with doing a couple cases in which one of them actually truly achieved tolerance. So how can we do that more routinely so that when we transplant somebody, they're no longer taking drugs, they're going to accept their organ forever, and they can have a normal lifespan with the opportunity to have kids and everything else without having to really alter their choices based on the fact that they're a transplant recipient. I remain optimistic that we will continue to improve in terms of any of our organ replacement therapies. What I would love to be able to see is where, we didn't have to rely on transplant as the solution set, and we're getting better with the mechanical support. For hearts, we're nowhere near where we thought we would be with mechanical support for lungs, but we will continue to improve with transplant. And the beauty of science and innovation is that as long as we're focused on the important questions, we're going to be able to do it better. So whenever I'm talking to somebody who's potentially entering the field, I'll always ask them, what is your passion? And what do you really want to achieve during your career? If you're focusing on the big problems within transplantation, so long-term outcomes or the improvement in the availability of organs to put into it, that's a very valid life's work, and it will have meaning and tremendous importance. There are very few things that we do in medicine that adds a number of life years that you're able to add in the field of transplantation and treatment of end organ failure. That's really a gift, and that's something that you can actually build your happiness off of. I love telling the stories of the Christmas Eve transplants. Most people think I'm crazy. But I love the idea of going into the operating room at midnight or 2 in the morning. Sounds like a strange time, but you can get done by the time that your family's going to be waking up and opening presents. And walking out to tell family, Merry Christmas. That's really the best gift you can give. I remain optimistic around what we do. I always am interested when we may be trying to apply technologies to situations in which there's not a clear benefit. And I could think about the robotically done lung or heart transplant. Things can be done. Now, the flip side of this is that there may be real advantages if we're applying it to the right patients. One of the things we rarely talk about, particularly in lung transplant, is our surgical incisions actually create a defect in the respiratory mechanics. We say the lung doesn't breathe, we breathe the lung. So there may be a real significant advantage of using less invasive incisions to be able to overcome the early morbidity of a transplant using a thoracotomy or sternotomy approaches. I just want to make sure that when we're using that technology that we're focusing on what are we trying to address, not just using it as a marketing strategy without truly a benefit. And that gets into almost any innovation. There's always the hype of you can do something. Does it really provide a benefit? And are you thinking about it in a way that's addressing a true problem? And this gets into the fascinating things of, all right, we are demonstrating we can use technology to move it forward. Let's demonstrate where it actually provides a benefit. And I actually think it can. ISHLT has evolved from being a heart focus to now a heart and lung focus to now an organ failure or thoracic organ failure focus. It's also become more of or less of a surgeon-focused organization to multidisciplinary teams, which I think is tremendously beneficial. And I look at the people who are my mentors and the individuals that I looked up when I was training in the 80s, the Norm Shumways, the Alec Patterson and Joel Coopers, et cetera, to where we are now, and the focus on how we actually use multiple team members, physicians, allied health, to meet the needs of the patients, the families, and to be able to take care of them in a seamless manner through the rest of their days. We have enabled the exploration of the big problems. We have enabled some of the solutions that have moved survivorship from what was pretty scary to what is really pretty good. It's not where we want it to be. We continue to want to improve. But my God, the idea that we have a much more reproducible therapy for people who otherwise would not be with us is pretty spectacular.